Uh, all right, is it coming through? Sharing? Okay, cool.
Yep, looks good.
All right. Well, hello, everyone. Thanks for spending your lunchtime with me. I'm Dr. Zach Hansen, Medical Director of the Division of Addiction Sciences at the School of Medicine here in Huntington, and also Department of Family Medicine. And so sort of going to take a wide view of substance use in pregnancy and postpartum, going to try to hit all the major sort of conditions and then just the basics. And then, I guess if there's need, we can always sort of dig in deeper in the questions or, with another session down the road. So first thing I always like to define is, what are we talking about when we're talking about substance use disorder? So it's a recurrent use of alcohol or any other drugs causing significant impairment and health problems, disability, or failure to meet major responsibilities at work, school, or home. So it's adversely affecting your life. It's defined as a chronic relapsing disorder characterized by compulsive drug seeking and use despite adverse consequences. And so I always like to sort of point out two very important words in that definition. The first is chronic. It doesn't go away. It's not acutely treated for 2 weeks and then it's magically gone. It's chronic. It's going to be there, lifelong. And then the second is relapsing. In a perfect world, we would love that relapse was not a part of the disease, but it is. And in the same way, for most chronic medical conditions, you're going to have relapse. You're going to have A1Cs are going to go back up, blood pressure is going to go back up, return to smoking, etc. And so relapse can happen and needs to be addressed. It doesn't mean that we failed or they failed. It just means we need to look at our treatment plan. And it's a complex treatable condition. For most people, it's chronic. Relapse is possible even after long periods of abstinence. It requires continued treatment. And so you got to work a little bit harder when those relapses have happened to diminish their intensity. And then you've got to find the treatment course that works best for that individual person. You can't say that everybody needs exactly, one type of treatment. We got to find what best fits their needs to help them recover and lead fulfilling lives. And so just looking at what the criteria for substance use disorder. So obviously taking the substance in a larger amount or for longer than you meant to. There's a desire to cut down or stop using, but you're not able to. You're spending a lot of time using, or recovering from the substance. You're having cravings or urges to use the substance outside of the way that it was prescribed or the way that it was meant. You're not managing to do what you should at work, home, or school because of the substance use. Continuing use even when it is causing problems in relationships. You're giving up important social, occupational, recreational activities because of use. You continue to use even when it puts you in danger. You continue to use even when you have physical or psychological problems that are caused by the condition or made worse by the substance use. You're needing more of it to get the same effect, which is tolerance, and then development of withdrawal symptoms. So if you stop taking it and you're sick, then you've got that sort of physiological withdrawal sort of syndrome. And so, like a lot of things sort of in the psychiatric world, we've just sort of got our check boxes, and so it's very easy to sort of screen because you're just asking the questions. And then depending on the number of questions that they say yes, then you can sort of classify how severe. So 2 or 3 symptoms, you're looking at a mild, 4 to 5, moderate substance use disorder, 6 or more, severe substance use disorder. And you can really, put that particular substance in the questions, and you can screen for opiates or benzodiazepines or methamphetamine or whatnot. And then you can also further classify it from a billing standpoint in early remission and sustained remission on maintenance therapy and controlled environment. So there's always those qualifiers, that the billers love and insurance like to deny us for. So this is sort of my soapbox slide. These are all things, that we sort of hear for those that don't sort of understand substance use disorder or that may have a significant bias or stigma related to those individuals with substance use disorder. It can happen to me. I've had literally hundreds of patients that have come through where their substance use has started with an injury, that they can just quit. Withdrawal is very, very real and is very difficult to work your way through when you know that that medicine or that drug will make it all go away. That is a moral failure. Physiological dependence is very real. That they don't deserve Narcan. We don't withhold any other medicines that are life-sustaining or saving, and so we shouldn't withhold Narcan from these individuals. It's a choice that they make. We don't choose to be sick. We prefer to be normal. And again, that's why a lot of patients continue to use, is because they can't stand that withdrawal. And then there's a huge difference between those individuals that are chasing sort of the proverbial high versus those avoiding being sick. And most patients that are coming into treatment are probably tired of being sick and are just trying to prevent that versus actually chasing sort of that euphoria, that dopamine release that they were initially. And so we have to be very careful with our biases and the way we sort of look at these individuals. So we'll start off with the alcohol, which is, I guess, probably telling after Super Bowl Sunday. Maybe a few people out there with hangovers and headaches today. So 52.5% of the U.S. population identify as drinkers. So that's about 135 million, and about 86 million of those are considered to abuse. And so sort of three types of abuse that we see with alcohol. One is heavy drinking, which is 6.5%. So that's 8 drinks for a female, 14 drinks for a male per week. Binge drinking, 23%, which is 4 drinks for a female, 5 drinks for a male in a particular setting. And then underage drinking on our college campuses, at 9.3. So alcohol is primarily as a central nervous system depressant. Sort of makes us relax, sort of chill out, and sort of calm down to some extent. Although obviously some people are drinking, get very rowdy, and end up in fights and whatnot. It can be very dangerous in withdrawal. And so if someone is identified with an alcohol use disorder, we have to be very careful in what treatment we recommend for them to make sure that they can sort of safely go through that withdrawal process. It can cause seizures and death. It's one of 2 substances that can be deadly in withdrawal. So detoxification can be done with benzodiazepines. That's sort of the gold standard at this point. And so you have to make a decision of inpatient versus outpatient detoxification. Outpatient can be done if you trust the patient to take the medicine, if you feel that they have a strong support system to sort of monitor their at home, no significant underlying psychiatric comorbidities or physical comorbidities. And otherwise, you can do it inpatient. And then there really is 2 types of taper, symptom-driven versus scheduled taper. So scheduled taper is you're going to get the medicine no matter how you feel, versus symptom-driven is they're going to continue to reassess their withdrawal symptoms. And once they meet a certain point, then they're going to give them medicine. But typically can be done in sort of 3 to 5 days. And then there are 3 meds that we use typically for maintenance of sobriety. That's naltrexone, acamprosate, and antabuse. And then obviously, with any substance use disorder, you want to include therapy. So CBT, peer support, self-help groups, AA are very beneficial and have very strong literature behind them. So sort of quoting a study, so sort of looking in the pregnant population, and about 80% of pregnant women were screened for alcohol use disorder in this study. But of those who screened positive, only 16% were advised to stop. And so, we need to make sure that we're at a level that not only are we screening, but if we get a positive screen, that we're well prepared to sort of to manage that yes and give them the options. There is no safe amount of alcohol in pregnancy. Effects really vary depending on their clearance rate, fetal development, sensitivities, genetic susceptibilities, drinking patterns, other co-founders. Some people can drink and there's no outcomes, and some people drink very, very little and can have adverse outcomes. Alcohol is a teratogen. It can affect fetal growth and development. You have fetal alcohol effects, or FAE, alcohol-related birth defects, and fetal alcohol syndrome. Studies have struggled to find a clear neurodevelopmental outcome related to alcohol consumption in those cases in which it's not clear in the beginning. But there was a study out of Washington that showed low rates of abnormal findings in preschool kids, but the rates of abnormalities increased at age 10 to almost about 100% of the kids had attentions with deficit language memory, and activity. And so we may not identify it early, but we will be finding it into the later years of elementary school in a lot of cases. And so sort of jumping back to the screening, so there's multiple sort of screenings, quick screenings that you can do for alcohol. So you got TACE, which is tolerance, annoyed about people asking, feeling like you need to cut down, or an eye opener. You've got TWEAK, which is tolerance, worrying about consumption, eye opener, amnesia, or cutting down. You have tolerance, which is the number of drinks to pass out or fall asleep, or the number of drinks you can hold without passing out. And so anything more than 5 is a positive for this screen. And then the audit C, which is how often do you drink, how in the typical day, frequency of 6+ in the past year. And then looking for other medical related issues with alcohol, you can look at blood alcohol level acutely. There's a phosphatidyl ethanol, which actually screens positive for up to 6 weeks after intake. You got fatty acid ethyl esters, which is 24 hours, and then the ethyl glyceride, which a lot of the toxicology screens are now doing, which is up to 5 days and can be present after an hour after an intake. So I know a lot of locations that are doing the urine drug screens are now sort of adding in the ethyl glyceride, which is very helpful. So moving on to marijuana, or THC, or cannabinoid use disorder. It's the most commonly used federally illicit substance, although it is now legal in some states. Concentrations have increased over time with purification process and legalization. It has some use for anxiolytics, pain control, appetite stimulation, seizure treatment. It actually is utilizing the natural cannabinoid system. So we have receptors in our body naturally. It is, as a controlled substance, is level 1, which is somewhat limiting in the ability to do research with it, but it's improving slowly. You can sort of see the psychoactive substance is the delta-9 tetrahydrocannabinol. Organic teacher would not be happy with me slurring that. You see a lot of delta-8, a lot of delta-10, a lot of different sort of offshoots that are working to sort of circumvent the legislations and whatnot, so they can be sold over the counter in a legal manner. So delivery systems, smoking, vaping, dabbing, ingesting, such as edibles, beverages, or tinctures, and then there's topical creams. Cannabis use disorder develops in about 10% of regular cannabis users and about 50% of chronic daily users. So it obviously has associated cognitive impairment, poor school and work performance, and there are some relation to psychiatric comorbidities with mood disorders and psychosis at higher levels. So what are sort of the outcomes related to cannabis use disorder? They recommend, the USPSTF recommends that everyone is screened for cannabis use disorder. And this can be done just by a simple question of how often do you use marijuana on a regular basis? And this is pretty effective at identifying. Drug testing can be done in the workplace. You have different THC and its metabolites that you can look for. It can be present for up to 6 weeks, depending on the sample. And so what do you do if someone does screen positive? You need to assess their use. You need to assess where they're at as far as their willingness to quit or seek help, and then sort of make referral as needed. And so there's most literature probably around therapy related to supporting abstinence from cannabis use or just with decreasing. And then there was a lecture I did, I think last year, that sort of talked about some of the medications, but there are no specific medications for support of cannabis use disorder. So looking sort of at some of the data as related to outcomes, there's a 3-fold increased risk of composite neonatal morbidity and death. And so, identifying these moms, these babies and mothers are at higher risk for adverse outcomes. There's about 500,000 pregnant Canadian women reporting cannabis use. There's about a 50% increased risk of autism spectrum disorder. And several studies have noted impaired neurodevelopmental outcome, particularly related to attention, visual spatial functioning, hyperactivity, problem solving. And many of these studies were performed at a time when cannabis was a lot less potent. And so the significance of this exposure is likely going to be higher and higher over time as the concentrations are higher and higher in many of the cannabis using patients and population at this point. But there's no current link to any congenital abnormalities at this time. So opioids, the one we probably hear and talk about the most. And so sort of two classes of opiates. You have prescription opiates, so hydrocodone, oxycodone, morphine. And then you have those that are sort of illicit, which is the heroin, fentanyl. So how do they sort of act? Respiratory depression, large dopamine release leading to the euphoria. Some patients have sedation. Some patients report energy with use of opiates. There is a very large dopamine release. So signs of intoxication, depressed mental status, decreased respiratory rate, decreased tidal volume, decreased palatal sounds, which is why they end up constipated, and then sort of the constricted pupils. So the classic withdrawal syndrome from opiates, abdominal cramping, diarrhea, nausea, vomiting, runny nose, sweating, shivering, goosebumps, from a central nervous system. You get some insomnia, anxiety, tachycardia, hypertension, restless legs. I think restless legs is the symptom that's most common for many of these patients. The restless leg syndrome, it can be very difficult to treat even with medication-assisted treatment. And then you have yawning, sneezing, dizziness, leg cramps. And so a lot of the opiates sort of use, all sort of began with the prescription opiates with pain as a fifth vital sign, which happened, a few decades ago, and this sort of started us down this road that we're sort of struggling to get back on track with. So, and then medication-assisted treatment, methadone and buprenorphine, are sort of the gold standard at this point in time for treatment. So as far as outcomes, related to opiate exposure, so on the left, you'll sort of see these are the obstetrical outcomes, so increased risk of placental abruption, fetal death, intraamniotic infection, obviously higher if there's IV use, fetal growth restriction, fetal passage of meconium, which puts them at risk for pneumonia, preeclampsia, elevated blood pressure, premature labor, premature rupture of membranes, placental insufficiency, miscarriage, postpartum hemorrhage, and septic thrombophlebitis. And then obviously the classic sort of neonatal absence syndrome or NALS. It can affect their sleep, tremor, increased tone, myoclonic jerks, convulsions, poor suck, poor feeding, spitting up, increased temperature, respirations, loose stools, diarrhea, yawning, sneezing, vomiting, et cetera, et cetera. So obviously a lot of symptoms can be found in these babies with NAS or with NALS, neonatal opiate withdrawal syndrome. So stimulants, the other SUD, so sort of two class of stimulants. You've sort of got the illicit, which is the methamphetamine and cocaine, and then you've got prescription stimulants, which is amphetamines and methylphenidate or the ADHD meds. Stimulants by and large release a very large amount of dopamine, which is part of their sort of addictive potential and properties because they make patients feel so good. And so prescription use, ADHD, hypersomnia, narcolepsy, and then the illicits. Cocaine was the original sort of stimulant, popular in the 80s, and it's making a comeback now. So cocaine sort of works by blocking the uptake of dopamine. And so typically there's some activity that causes the release of dopamine that's sort of added to or done while utilizing cocaine. And so the classic example is having sexual intercourse on cocaine that causes the dopamine release, and the cocaine sort of blocks it from being uptake. And then methamphetamine, which actually causes release of dopamine and the uptake, which is why it has such a large amount of dopamine release. So with methamphetamine, there's sort of two waves, sort of historically. One is a pseudoephedrine base, and now the P2P or phenylpropanone, which is sort of being created likely in Mexico and then sort of crossing the borders. The issue that you run into, particularly with methamphetamine, is that the euphoria or the dopamine release sort of wears off before the stimulant effect or the wakefulness does. And so patients will be wide awake, but they'll be having that sort of drop of dopamine. And so they'll use again. And then you sort of have an additive effect, which is why sometimes patients will be up for 48, 72 hours at a time because the stimulant effect of wakefulness, hasn't sort of worn off until they crash. So with intoxication, you've got tachycardia, hypertension, hyperthermia, diaphoresis or sweating, mydriasis, and then alterations in mental status, including anxiety, agitation, violent behaviors, and seizures. And then sort of there's a lot of debate as far as the withdrawal related to stimulants. Sort of the physiological, sort of is that crash or exhaustion, not a whole lot of sort of physical manifestations, but then you sort of have the mental withdrawal, which I think, you know, in sort of my experience is a lot more difficult because all of the dopamine has been released from the brain. And so patients will just sort of feel this generalized numbness / lethargy / depression, and they just don't feel anything. And sort of a classic example is like, you know, they win the lottery, you know, get $1 billion, and they're like, I don't care. It doesn't really, you know, it doesn't make them happy because they have no dopamine to be released when good things happen. And it takes a long time for them to sort of equilibrate and get back to normal with that. So what are the effects, prenatal exposure of methamphetamine or amphetamines? So increased rate of spontaneous abortions, increased fetal demise, placental abruption, prematurity, growth restriction, but no known teratogenic effects. So what about the exposure, you know, post-delivery? Usually noted between 48 and 72 hours of age. You have some central and autonomic neurological symptoms. So the tremor, high-pitched cry, irritability, excessive suck, hyperalertness, apnea, tachycardia, and a lot of it sort of depends on the dose. And then sort of looking at the longer effect, impairments in social and sustained attention, behavior, self-regulation in school-age children, some subtle language changes, cognitive delays, increased ADHD symptoms with poor auditory attention and reduced short-term verbal memory. So again, you know, we're going to see some issues related to the scholastic course, you know, with these children. All right, and I think the last sort of one is benzodiazepines. And so this is sort of your classic downers. So like a Xanax, Valium, Klonopin. So with intoxication, you're going to be seeing slurred speech, incoordination, unsteady gait, cognitive impairment, anterograde amnesia, and inability to create new memories. And so with overdose, you typically see nystagmus, kind of stupor, coma, respiratory depression, mild withdrawal, you know, usually 2 to 3 days after consistent use, you're going to see anxiety and some insomnia, sort of moderate, 2 to 14 days, sleep disturbance, irritability, anxiety, panic attacks, tremor, diaphoresis, poor concentration, nausea, vomiting, weight loss, palpitations, you know, just a lot of the classic symptoms. But then you can have very severe sort of withdrawal, you know, from benzodiazepines with generalized tonic-clonic seizures, psychosis, transient hallucinations, and deliriums. And so this is the second substance that withdrawal can be deadly if not managed appropriately. And so we have to be, again, if we identify them, we need to determine the best treatment course for detoxification and withdrawal management. And so there's, again, 2 different ways to sort of go, inpatient versus outpatient. Inpatient, typically, if they're very high dose, it's essentially 100 milligrams of diazepam equivalent, then they need to be hospitalized, and this needs to be done inpatient. Or if they've had a failed outpatient taper, or if they have complicated medical comorbidities such as seizures. Otherwise can be done as an outpatient. As you can sort of see, it's a very long course, you know, typically 6 to 10 weeks. And so you're doing a gradual reduction, 25 to 50% drop in dose every 1 to 2 weeks. And so you're looking at 6 to 10 weeks in order to get it done. And then CBT is the best studied psychosocial intervention in working on relaxation training, education material, self-help books to really help them learn how to cope with life without this sort of anxiety busting medication, or, you know, just self-control of their anxiety. And you'd really need to address the underlying reason that they were taking it in the first place, such as anxiety or insomnia. All right, so we're sort of finishing up. So what are the sort of the take-home points? You got to ask the question specifically. If you don't ask specifically what the patient is taking on a regular basis or even an intermittent basis, then you're not going to be able to identify, you're not going to be able to come up with the appropriate treatment. And then once you identify what they may be taking, what you may be exposing the infant to, or then you need to sort of talk with them about what the risks are. And you need to document that risk, because if we have these babies being born and we haven't clearly documented the risk, then some could argue, that we are not doing our job and are potentially doing malpractice. And so you need to document your discussions related to risk, what treatment was offered and what referrals were made. We need to be trying to put an integrated team approach in place. It's more than just the doctor, it's more than just the nurse, it's more than just the therapist or the case manager. We need to work together as a team for the best outcomes. And then each substance brings its own challenges, barriers, risks, and complications. And we need to be aware of these. We need to educate the patients, and we need to address them as best we can. And with that, I believe I'm done.
Thanks, Dr. Hanson. That was great. We did get one question while you were presenting in the chat. I don't know, Laura, if you want to unmute and just go ahead and ask it, and then we'll open it up, obviously, to everybody else.
Yeah, I was just curious, there's a lot of, with regard to impact of alcohol use on the developing fetus and in early childhood, there's a lot of attention paid to fetal alcohol syndrome. I was just curious about what other kinds of developmental disorders we see in kids who are exposed in utero, other than the classic kind of fetal alcohol syndrome.
I think the difficulty sort of lies not in that we're not seeing sort of this defined syndrome related that we can identify at birth. There's sort of the classic appearance of an infant that has fetal alcohol syndrome, and so it's easy to sort of identify. We can diagnose it, we can label it, and then we can sort of follow it over time. But what we're finding is, we're treating a lot of these infants, in the NTU or in the hospital, or maybe we're not identifying them. And then they just sort of disappear out into the general pediatric and family medicine realm. And then they get into school age, and they start having the issues with attention and with concentration and intelligence and whatnot. And at that point, we're already so far behind in necessarily being able to address these behaviors, because they're somewhat set into their day-to-day functioning. It would really, in a perfect world, there's a lot of research and a lot of work that needs to be done. We need to identify these infants, through the obstetrical care. We need to put them in a registry, and we need to track them, and then we need to clearly define what symptoms they're having, and then we need to be able to design specific treatments, in early intervention to try to address those symptoms and see if we can make them sort of neurotypically normal, once they get to a school age, so that you wouldn't be able to pick them out from the other kids. But it all starts with identifying them early, and then we need to come up with what sort of interventions we can do. But without the clearly defined syndrome that you can diagnose, they go undiagnosed until much, much later in their life.
Yeah, and I know we don't have a case, but I'm thinking of a case, and I'm curious about what other people are experiencing, because I think we, with all of our attention on opioid use disorder and methamphetamines and overdose in the crisis, we sort of forget about problematic drinking during pregnancy and the long-term effects on children. I have a young woman that I work with who, two of her, has had a third child, and her other two children, they had severe speech delays, very delayed walking, like not until almost 2 years old. Now, birth to 3 was involved. She said they were tested for autism, and they didn't test as being autistic, but clearly have some cognitive delays also. I've never met the children, and I see her virtually, so it's kind of hard for me to. They run around in the back a lot, or one runs around and one kind of crawls around in the back. And we were able to identify her alcohol use disorder in treatment. She struggled to remain sober while pregnant, and the baby was removed after it was born, and she's working with CPS now. But I was just curious about like delays in walking. Would that be potentially attributed to fetal alcohol syndrome? I mean, to exposure in utero. And then also what other people are seeing in general in terms of alcohol use in pregnancy and how it's being addressed. So that's like throwing it out to the group also.
Yeah. I will say, I've been doing addiction medicine for 12 years. And I don't ever remember getting a referral for a mother who was identified with an alcohol use disorder during pregnancy. And I've literally, had a hand in or been a part of treatment of thousands of people in the Cabell County and Huntington community. So I don't know if there's a stigma, or they just don't feel like it's an issue, or we're not screening, but we surely don't identify. We do a very, very poor job identifying issues. And I was talking with a patient even earlier today, and she's like, my mom just calls me a functional alcoholic because I go to work, I do all the things, I take care of the kids. Nobody knows any different than when I go home and then I drink every evening. Nobody, only the family knows, and she doesn't want help, and there's nothing they can do, and she's able to function. So, I think statistically, there was a study that came out with the Journal of American Medical Association a couple of weeks ago that someone shared. And the overall volume and morbidity related to alcohol probably surpasses those of the opioid use disorder when you start adding in the cirrhosis and heart attacks and strokes and the other comorbidities that go along with alcohol use. It is more deadly and more cost to our healthcare system than opiates, but it doesn't get any of the press. And it's just so hard to identify.
Yeah, just following up on what Laura said, the CORD study, that they did, it was 12% of women, CORDs had, so we're missing a whole bunch of them. And should we be, many hospitals and communities have started screening all women for Hep C, Hep B, and, drug screens, but that drug screen doesn't include alcohol.
Yeah.
And should we be getting an ethyl glycuronide or something like that? Because I think there is actually more stigma on drinking in pregnancy than there is in opiate use. Our patients are pretty open about their opiate use. I don't think that we're just missing it. There's no way it's, we're seeing it, because same way with you, Dr. Hansen. I haven't seen that many, one maybe that, had an alcohol use problem during pregnancy, but they only admitted it years after delivering a baby. We're just not picking them up in pregnancy.
Yeah. From a policy standpoint, it would be interesting if we were to propose, screening at all OB visits, with the urine drug screen, with the glucuride, or even a little bit crazier. What would it look like if we did a hair sample on everybody and sort of took this longer look back? Come into mother baby, you get your IV, you do your blood work, you give your urine, and then we pluck some hair and then look back at it to see what the baby's been exposed to, so that we can address it. It'd be a tough sell, but it would be very interesting to see. And obviously the cords are helpful, but in my opinion, the cords are always kind of hit or miss. Sometimes we identify things, sometimes we don't. We miss too much.
And the cord isn't, how is the cord at picking up alcohol use? And
I don't think it's very good.
I'm curious about if other people, anyone else on the call is it asks or regularly screens for or is seeing much alcohol use. Certainly in our IOP with our non-pregnancy population since the pandemic, our referrals for alcohol use disorder have increased. So we know that the pandemic, much like opioids, increased people's use of alcohol and other substances.
I know that I see patients out of our OBGYN department, so that's my cohort. And I always screen, but I can't even think, and I've been with the department now for over 25 years. I could maybe on one hand count the people who have said, you know, yes to alcohol use in any form. So so even though I'm verbally screening, I'm not getting a lot of you know, positives. And that's every patient, that's every new patient. I don't do it every visit, but on their new appointments I do.
I mean, we screen in terms of asking them, I think, but that's about the level we screen. And then I just pulled up one of our cord stats that we use. Alcohol is not even included in it. It's not, you know, so that study that they did, they actually have to look for it specifically. So in our cord stats, it's not included out here at East, at least. So we have no idea.
Any other comments or questions?
This doesn't relate to fetal alcohol syndrome or alcohol use disorder, but there was a patient that we saw in labor and delivery who reported that she had been using Delta 8 THC, and she'd stopped in beginning of January. I think January 1st is when she said, but her urine drug screen with confirmation came back positive for cannabis, but was negative on the metabolites. And I was curious about like whether Delta 8 has been like studied, like investigated in regards to cannabis use.
Yeah. It's, you know, and I'm, you know, Dr. Berry's probably much more of an expert than I am, you know, but the theoretical issue, you know, with the Delta 8 and all the different other sort of cannabinoids that they're selling over the counter, whether that be CBD or the Delta 8, is there's no checks and balance. There's no quality control. You know, there was a study done, it was probably 5 or 6 years ago, in which they looked at CBD products, you know, and they had various levels of CBD that was in them, and they claimed no THC. And over half of them, you know, had THC in it, even though they said that it didn't. And then the levels were grossly inaccurate as far. And so with the lack of quality controls, you know, most patients, you know, that use CBD are probably getting some level of THC as well. And I can't tell you the number of patients we've had come in using CBD products that are then testing positive for THC. But as far as the specifics, you know, the effects of if you did have a pure Delta 8, I don't know if that literature is out there. I haven't seen it. I can't say that I've done extensive search to see, but one would assume that if it's working through the same receptors, you know, that you would expect sort of a similar effect on the fetus as you would with the regular Delta 9 THC.
And with regard to testing, what we see clinically is, and these are with patients who, both study patients as well as clinical patients, and study patients tend to be pretty honest, because like nothing's going to happen to them if they're honest. There's no consequences. So they'll show up for THC for a long, long time if they're primarily using Delta 8. I'm talking like 6 months after discontinuing Delta 8. But on confirmatory, it's negative for THC, but on the sort of the instant test, they will pop positive for a long time. And usually on the confirmatory, it will indicate some kind of adulterant. And that's like the sign to me that it's a Delta 8 related positive that was the initial positive. It always references an adulterant, at least that's how it shows up on our drug screens. And literally like sick, and this would be a heavy user of Delta 8, but for a long time afterwards, they're positive. And that's important when we work with patients who have, you know, are looking for a job, and the job isn't necessarily doing a send out, and they may come up positive, even though they have discontinued use for a long period of time. And Delta 8, I mean, we're treating a young man right now who is psychotic. and his primary substance is Delta-8, and he's on the DDU right now, and he's really, really ill. And so again, like this idea that Delta-8 is not a big deal because you can buy it legally is just inaccurate, as we know.
Thank you.
Anyone else? Been a great discussion so far. Well, if there aren't any other additional questions or comments, we can let Dr. Hansen go to his next meeting, as it's not in the same building. So Dr. Hansen, thanks again for presenting. We really appreciate it.
Yeah, that was
fielding the
great.
questions.
Thank you. I felt very rushed, so hopefully the content will come through. And if not, please share my slides because there was a lot on there. I think that it would be helpful. So, all right.
And we'll have
great afternoon.
Yeah, we'll have you back. Don't worry. We'll be asking. Excuse me. So we don't have a case, so we are fairly early. We still have about 15 minutes. Just to let you guys know, but we can obviously get into more discussion or questions, but just to wrap things up for this session a little bit, we will have our next session on March 13th, same time, 12 to noon. It's going to be around homelessness and access issues, and Jennifer Price is going to be presenting on that from Marshall. So be on the lookout for the announcements and the reminders there. But we still have some time, so we won't have to keep anybody if we don't want to, but I also want to open it up for any additional comments or questions or anything like that. So.
I just, Dr. Shakari was on here, and we actually had a patient in November who came in from the methadone clinic, and her methadone levels it was not detectable. And that's observed. And so unless somebody's selling her, methadone at the methadone clinic, but then she went to split dosing and her levels were normal. So it really is important that split dosing's she was probably metabolizing it. And she actually came in an active withdrawal on methadone with single day dosing. And the testing confirmed that. And like I said, short of somebody at the methadone clinic not giving her methadone, it would be hard to false that. So just a reminder on those patients, and that. And then just a question, if people have been having trouble with kind of required day report testing, showing things different than our treatment patients, because I've had to go to court a couple times. And so I don't know if anybody else has had that.
We've struggled we have a zealous prosecutor in Mon County that likes to do blood testing. And we have struggled with multiple patients showing up as having very, very, very low levels of methamphetamines. Like the cutoff is 5 and they're at 6 or, something like that. And we've, based on patient report, there's not a great chain of custody. Like they don't wipe their fingers off before they test them. And both of these individuals work in kind of a consumer setting where they're handling money. And our theory was that there may be methamphetamines on the bills that they're handling. And when they wore gloves, they generally tested negative. So it seemed to confirm that. But we had an individual who basically did not have custody for her children for like an extra 9 months because of these tests. And we worked with her really long term. Like there's no way she was using methamphetamine. She kept a full-time job. I mean, she did not present
Right.
as someone consistently using. So that was been my experience with those blood tests specifically.
Yeah, and we've had the same thing with fentanyl. And with somebody who's in active use isn't handling life like you just said. It's just not, they don't. And so, yeah, we're seeing the same thing out here. So interesting.
Anything else for the good of the group? All right, well, we'll give everybody 12 minutes back. Hopefully be able to grab a bite to eat or something like that for lunch real quick. But we appreciate everybody coming. And like I said, we'll see you in a month on March 13th. All right, everybody, take care.
Yeah.